very commonly in children with atopic dermatitis, they can have secondary infection. And usually it's bacterial infection with staph. So I try to take a routine approach. First of all, recognize if you have honey-colored lesions on top of atopic dermatitis, it's probably impetiginized. Staph and strep are the most common. You can have co-infection of both. I'll consider doing cultures of the skin, but first I try to take a medical history. That's important. For instance, if there are family members who are healthcare workers and or if there are family members who've had recurrent abscesses, then I'm thinking there's more chance that it could be MRSA that's colonizing the skin. I also want to know if the child's had repeated infections in the past, in which case those are two reasons I might culture to see what the bacteria are and see what their sensitivities are, which might influence my choice of systemic therapy. I also would like to evaluate the patient in terms of how are they doing with their eczema, because we know that if you have flaring eczema with a lot of staph on the skin, many times anti-inflammatories are going to be the effective therapy, whether it be topical steroids or systemic therapy that'll cool down the inflammation. Although if they are secondarily effective, they may benefit from oral antibiotics as well. Topical antibiotics usually aren't that effective in truly infected eczema. So while some people will use mupirocin or other agents, most of the time we'll use appropriate anti-inflammatory therapy. And then if you have an active infection, then you can decide whether you'll treat topically or systemically for a period of time to get that under control. So with impetiginized eczema that's caused by staph, we had a lot of concerns over many years about resistant staph and MRSA, methicillin-resistant staph. A consequence of that concern over many years is that patients are more liberally given clindamycin for staph infections. And now what we're seeing in our practice is many times impetiginized eczema that's resistant to clindamycin. And they'll actually respond to what we consider to be wimpier antibiotics in the past, such as cephalosporin, because they're cephalosporin, the staph cephalosporin sensitive, even though it's clindamycin resistant. So I'll still, often infected eczema in my community, I'll use cephalosporins or an extended spectrum penicillin as my first line agent. And then I'll culture, depending upon the history, to see if I have to be concerned about methicillin resistance. Another thing you should keep an eye out for is herpes infections in atopic dermatitis. Eczema herpeticum clearly can be very, very serious. I'll often have families come in who had what was thought to be eczema herpeticum. We can't even tell because a week and a half might have occurred before they came in to see us. An acute eczema herpeticum is a very classic appearance with cluster of grape appearance of blisters. I'll actually show parents pictures of cutaneous herpes to both get a sense of that's what the lesion looked like and also to train them in the future, because identifying early onsets of recurrent eczema herpeticum can really change the course of the disease, because oral acyclovir or similar agents can turn it off right away. A lot of questions I get as a practitioner is, what can I use as a steroid-sparing agent for a patient under 2? And this is tricky because our traditional active prescription anti-inflammatory agents, beyond topical steroids, so meaning the calcineurin inhibitors or topical crisaborole or PDE4 inhibitors, aren't approved under age 2. Now generally, guidelines will say they're appropriate to use if you need something other than topical steroids for disease control, whether it be the Academy of Dermatology guidelines or the Allergy Immunology Quad AI guidelines. They say they're reasonable to use, so I tell my physicians, fight for them, try to get them approved. We look forward to future studies where we may get specific approval under age 2. That'll make it easier, but in the meantime, if you need a steroid-sparing agent, push for it because it may be the right thing for your patient. So a lot of people ask about sleep disturbance in atopic dermatitis. There was one article that said that melatonin worked, but I found it not really useful in practice. And even in that article, it didn't make a big difference in the overall eczema in that individual. My takeaway about sleep disturbance is that if you adequately control the disease, whether it be with topical or newer systemic agents, when you get the disease under control, the sleep disturbance will go away, and that's an outcome I'm going for.